Dr. Anvita KACHHAP.
Good afternoon, everyone. My free paper is on clinical characteristics and treatment outcomes of optic neuropathy associated with sarcoidosis. Sarcoidosis forms a spectrum of autoinflammatory disorders of unknown etiology characterized by development of immune activation leading to immunologic cascade that results in an inflammatory infiltration of tissues with granuloma formation and later fibrosis. Ophthalmic complications arise in 10 to 50% of the patients. The ophthalmic complications included in my studies are listed below. The aim of my study is to study the clinical characteristics and treatment outcomes in patients of optic neuropathy related to sarcoidosis. Materials and methods. The study was conducted on 11 patients with visual disorders assessed in our department. The investigation protocol. Initial investigation, a series of blood investigations and imaging studies were primarily done to exclude demyelinating systemic autoimmune and infectious or metabolic causes. Granulomatous cause consideration. Granulomatous optic neuropathy was considered when other causes were ruled out. Additional investigations were conducted for patients showing systemic features of sarcoidosis. Diagnostic criteria for sarcoidosis. Histologic proof confirmed granulomatous disorders requiring treatment. Clinical evidence, typical radiological features, hypercalcemia, raised serum ACE levels, or characteristic gallium scintigraphy or PET findings. Exclusion criteria, 17 cases were excluded as they did not fulfill the diagnostic criteria for diagnosis. Ethical considerations, ethical approval was obtained, patients provided informed consent for inclusion. The results, 11 patients were included in my study. The mean age was 42.5 years. Predominantly, the female gender was involved. Clinical features, systemic sarcoidosis diagnosis, concurrently diagnosed in 6 patients, previously diagnosed in 5 patients. Systemic involvement, respiratory system involvement was predominant in 8 patients, involvement of orbit and lacrimal glands in 3 patients. Histologic diagnosis confirmed in 9 patients through respiratory tissue biopsy and orbital biopsy. Clinical characteristics of optic neuropathy. Optic neuritis syndrome. 9 patients presented with subacute optic neuropathy evolving over days. Unilateral cases were seen in 6 patients and bilateral cases in 3 patients. Progressive neuropathy. 2 patients experienced slow progressive unilateral optic neuropathy. Symptoms and visual field effects. Pain was reported by 3 patients. Visual field defects included central scotoma in 7 cases and hemianopic defects in 2 cases. Imaging results, the MRI findings showed enhancement of optic nerve and sheaths in 8 patients. 2 cases showed optic perineuritis with predominant sheath involvement. Normal imaging was seen in 3 patients. Treatment, corticosteroid therapy. All 11 patients were treated with oral corticosteroids. 4 patients required IV methylprednisolone before transitioning to oral corticosteroids. Immunosuppressive therapy, 3 patients were given azathioprine and methotrexate due to relapse or incomplete response to corticosteroids. Follow-up, median improvement in visual acuity was plus 0.5. Subacute group showed significant improvement, and progressive group showed no improvement in visual acuity, but resolution of inflammation was seen. Relapse, 3 patients showed relapse. Unique observation in my study, in perineuritis patient, thickened optic nerve sheath was the predominant finding. Both improved with corticosteroid therapy. Discussions. The key findings of this study are clinical presentation often resembled optic neuritis, though it was less painful and sometimes more slowly progressive. Concurrent intraocular inflammation was uncommon, and 64% of the patient had no ocular involvement historically. Most patients improved significantly with corticosteroid treatment even after delayed intervention. However, relapse occurred in 25% of the cases, often requiring immunosuppressant therapy. In severe cases, a subset had progressive disease with widespread neurological improvement, poor visual outcome, and required higher dose of steroid, immunosuppressants, or biological agent. Meningeal inflammation was observed in these cases and in some with subacute course. Mechanism of optic neuropathy. The These include optic nerve inflammation, compression by inflammatory masses, ischemic complications, granulomas, or meningeal inflammation. The condition is rare in sarcoidosis, previously reported in 5% of ocular sarcoidosis cases and less frequently in systemic sarcoidosis. Management: high dose corticosteroids, oral or IV, followed by slow tapering, are recommended. Relapses should be treated promptly using immunosuppressive therapy, and cases of neurosarcoidosis require prolonged higher dose of treatment and potentially biological agents for refractory disease. These are my references. Thank you.
When you have sarcoidosis, you have anterior segment manifestations. How many cases had a candlewax appearance?
Sir, around so 50, we had 11 patients, and almost 5 patients had candle wax.
What was the incidence of the granuloma of the disc, the retinal granuloma?
So that incidence was low.
How many did you evaluate for bilateral granulomatous pan uveitis? Sarcoidosis is one of the important causes of a granulomatous pan uveitis, and the other deficient diagnosis of granulomatous uveitis are Vukatkayangi, HIV, sarcoidosis, Behçet's, tuberculosis, syphilis, Epstein-Barr virus. Acute uveitis is about 40% in these cases, and the chronic uveitis is 60%. Besides, you have to look for focal perivascularitis and venous occlusion. And yes, that's right. Other thing is that there's a condition which is called as Tulaza-Hunt syndrome. You know Tulaza-Hunt syndrome? Have you seen? Tulaza-Hunt syndrome is a condition where there is basically an autoimmune and an immunological reaction of the substances passing through the cavernous sinuses and the superior orbital fissure. Patient comes with periorbital pain, hemicrania, diplopia. This condition has to be differentiated from the sarcoidosis. What was the incidence of cavernous test? It was positive in sarcoidosis. Did you do it? It has to be done.
Yes,
how many cases of sarcoidosis has hilar lymph node neuropathy?
So, respiratory involvement is very common in sarcoidosis. Yes. In our cases, we had out of 11 patients, 9.
Whenever I have written an article on sarcoidosis, you have to group it as anterior segment and posterior segment. Anterior segment, you have got sarcoid plex like chalasia, lacrimal gland involvement, follicular conjunctivitis, follicular conjunctivitis, sicular nodule, heterochromia, uveitis, posterior segment, periorbital nodule, choroid involvement, candlewax exudate, focal perivascularitis, venous occlusion, glomerulonephritis.
So what would be your take-home message from this? What is the new thing that we learned from this?
Ma'am, the new thing, actually it's not a new thing, but the corticosteroid therapy, if given, it always helps in improvement of the symptoms, and it if given promptly and given in the right manner, it helps in having a good visual prognosis.
Take always the consultation of a pulmonologist.
Yes, sir.
So if there's a diagnosis of sarcoidosis, would you look for ocular signs and symptoms, or would you look for sarcoidosis on the basis of the ocular signs and symptoms? Which one would you?
Ma'am, first one, I guess, because first the patient will have respiratory and other manifestations. After that, he'll have ocular manifestations.
Not necessarily.
Thank you very much.
Yeah.
Okay. Thank you.